Hello, colleagues, ladies and gentlemen. Welcome to our session today. My name is Francis Ochen from the African Society for Laboratory Medicine. Very excited to be your host and moderator today. Our session will run for 1 hour. We'll take one presentation from the Zambian team, and then we'll get into the questions and answers. We have language interpretation services. Kindly select the language of your choice, either French, English, or Portuguese, depending on the one that you prefer. The session slides and recordings will be made available to you as soon as we have them processed. Colleagues, we continue to navigate the funding space, looking at what the additional developments are, and we also continue to track the impact of the current situation and strategies for immediate and long-term implementation. We've had two expert opinions, especially around this funding space and the funding disruptions, but also some of the experiences from the developing experiences from countries over the last few months. And we know that there has been deliberate actions informed by quality data to define the latitude of our services, the depth and latitude of the service delivery that we should be providing without necessarily compromising quality and access to current and future service delivery. So today, we are really pleased to have a team from Zambia who will be sharing with us the work they're doing towards sustaining their lab services beyond external funding. A really very structured, data-driven rationalization and optimization of services along the lab services delivery cascade. And to do this on behalf of the team from Zambia is Mr. Mweemba Muvwimi, and Mr. Mweemba is an assistant director for pathology and lab services at the Ministry of Health in Zambia. So allow me to hand it over to Mr. Mweemba, and we'll get back during the questions and answers. Mr. Mweemba, over to you.
Good afternoon, everyone.
Good afternoon.
I hope everybody's getting me loud and clear.
Yes, we are.
In this session, I will be sharing with you how we are sustaining the laboratory services beyond external funding using what we call a minimum health package for Zambia. So I have a number of slides that I'm going to share with you. Some of which will be discussing where we're coming from, what we've done, and also the current status of the laboratory services. So that's how our presentation outlook is going to look like. Zambia, like many other African countries, and on a recipient of US aid, specifically fight HIV, malaria, and TB. And also by the announcement of what executive order that caused international aid from its, and going by our of about 20 million plus, according to the 23 national statistics, and population service 115 which has 5 pieces that are able, and also about 29 instruments that we are funding, plus an additional of 400 gene experts. On the right here is the map of Zambia showing a distribution of the labs at various levels of healthcare provision, starting from small diagnostic centers to level 4 hospitals. What have we been benefiting from the donor support? The donor support was covering most of laboratory commodities. Close to about 50% of our commodities were being covered by donor support. We have also a number of personnel working in our laboratories who were funded by the donor support, and also some other oversight management programs such as mentorships and a few others. In the previous year 2024, a total of about $55 million plus dollars was committed to laboratory commodities, with the funding gap remaining at $31 million United States dollars. And out of this, the PEPFAR support constituted almost 71% of the committed budget towards laboratory commodities. Here, we are looking at a different supporting partners that have been supporting the lab. You can see that PEPFAR constitutes the biggest chunk of support, with a few others contributing a small percentage. And of all these, I think the smallest percentage was coming from government at 5%, mainly supporting chemistry, hematology, microbiology, and also histology. Apart from those other supports, PEPFAR also supports malaria elimination and response, with about 28 million committed towards malaria elimination, covering issues to do with anti-malaria medicines, insecticide treated nets, also other. PEPFAR as well funds founder of the health code systems, which we call here Smart Care, laboratory information system, commonly known as DISA, and also eLabs that are dedicated for sample pickup and results return in our facilities. Again, PEPFAR supports the sample courier system, covering issues to do with fuel expenditures for motorbikes and motor vehicles, as well as paying for the motorbike riders that deliver samples to testing facilities and results back to requesting facilities. Before the stop work, Zambia started actually moving towards self-sustenance by discussing with the National AIDS Council on the issues of HIV response using domestic funding mechanisms. And these meetings were held around December 2024, way before the stop work order was announced. The vision was to have the HIV response that is domestically funded and which can be sustained. However, before the mechanisms that were being discussed could be put in place, the USAID announced the pause in their funding towards HIV control. So following that, we had no option but to quickly carry out a situation analysis to assess the impact that were to come with this announcement on our health systems and self-service delivery. with the data that we collected and looking at the impact that would go with this, we had to engage the Minister of Health to lobby Cabinet for supplementary budget towards drugs and laboratory commodities. And then we convened a meeting to come up with what is called the basic health care package that would fit in within the approved supplementary budget. When this money was released, again, we saw that it was not adequate to cover the deficit of $39 million US dollars for laboratory reagents, which was earlier committed by PEPFAR. So a decision had to be made to remove certain testing modalities and stages to make sure that the testing services can be sustained. And this is what we called the basic healthcare package. So what was recommended for this basic healthcare package? The following were the recommendations. We decided that we will continue to do routine viral load testing, and then discontinue the early infant diagnostic test at birth, with now a new algorithm concentrating on at 6 months, 6 weeks, 6 months, 9 months, 18 months, and 24 months. Then we also had to optimize the viral load monitoring to 3 months for pregnant and breastfeeding women. Then we had to discontinue the genotype testing after first-line treatment failure. Then on the baseline viral load testing, we had to discontinue. After removing some of these things, we agreed that these may not alter or disturb our disease control strategies. So we'll now go on to specific types of tests that we concentrated on, like the viral load testing. We know what this does. It measures the number of viral copies present in a sample of blood. And one of the goals of antiretroviral therapy is to suppress the virus and sustain the viral load below the level of detection. And also durable viral load suppression is also highly associated with long-term treatment success. We know this, and the failure is a sign of ecological and clinical treatment failures. So for monitoring response to ART treatment failure, we could do a routine monitoring could be carried out in 12 months, and then at every 12 months thereafter, if the patient is stable on ART. For breastfeeding, pregnant breastfeeding women, we suggest that the viral load should be done every 3 months. And this was a preferred monitoring tool to approach to diagnose and confirm treatment failures.
All right. Okay, so on this slide, we're just trying to explain how we arrived at the minimum package, where we had to now remove the baseline viral load, as well as reduce for the pregnant and breastfeeding women, we had to reduce it to 3. Initially, it was 4. So now we had to reduce it, where now the third one, or the first one is in the monthly, the 6 monthly one, and then the 2 come along the as they are it's at some point during their antenatal visits. So with those now for the DR, where we agreed to remove to discontinue the first line HIV DR, is based on the fact that we have those unsuppressed clients who undergo the enhanced adherence counseling, which is done for like in a 3 months interval. This is where the adherence support is intensified. And it is expected that during that 3 months EAC period, the client is supposed, if they are adherent to the medication, they are supposed to now be suppressed. So that is based on that. And those who are not, still after the 3 months period are not suppressed, they are the ones that will now transition to second line. So we can move to the next slide. So this is the approach that I was just explaining regarding the EAC. So the patients with a high viral load while in care, they undergo the same EAC. CD4 testing is done. This is to screen for the opportunistic infections. And then at the end of the EAC sessions, that's the 3 months, we then repeat a viral load to check for suppression. And genotyping test is done. And if not suppressed, then we switch to the second line. We can move to the next slide. So here we are just trying to show you the testing performance in Zambia, how it's been so far. So I will just take you through our before. So this is more of our before the stop work order, and then we'll take you to the after the stop work order. So Zambia has achieved actually the UniAIDS 95 targets. And you will see that in all the three, we are above. So the first 95, we're at 98. The second one, we are at 98, and the viral load, the viral suppressed is at 97. So even if this picture looks good for the general population, the one for the children is not that good, which is on the next slide. And for the children, we can move to the next slide. Yes. So in the children, we do have where we have some gaps, some challenges. You will see that even the first for the first 95, where the testing, knowing their status, we are at 82%, and then those on treatment, 88%, and for the VL, we are at 95% for the children. So meaning that for the VL, in terms of those who are on treatment, for the suppression, we are doing well. But in terms of the EID testing, that is where the 82% is actually speaking to. So this is for our 0 to 4 age group. We can move to the next slide. Then for the cases of the viral load testing and suppression rate, this is based on our DISA. This is the data that is coming directly from the labs. So we have shown you the trends from 2018 to 2024, that it's been an upward trend where we've been improving, we've been doing well. And but even if we were doing well in terms of the testing and the suppression rate, so you will see that the test is the light orange, and the suppression rate, that's the darker orange that you are seeing, depending on how you see colors. Okay, we can move, but we can move to the next slide. So here we are just showing you that when we do the national picture, everything seems to be okay. But when we disaggregate now by age band, by sex, you will see that there are certain populations or certain age groups where we needed to pay attention. So in terms of the ones that are below the 90s, you see we have the children, the 0 to 4. Their viral suppression rate is at 78%. And also the adolescents, the 15 to 19, they're also not, their viral suppression rate is at 79. And this is in both the female and the male. So this is how our picture was looking like. And these are the same groups that we were now paying attention to, that we were doing targeted interventions to actually correct the situation in these groups. So this was before the stop work order. We can move on. This is the viral load suppression rates for the children. And this is based on Q2 2024. So why we are showing you this, because this is then going to speak to the picture that we are going to show you for our after the stop work order, the effects or the impacts of the stop work order. So we thought of just concentrating on the 2024, how it was looking like. So you will see that in the 0 to 4, we were at 76%. That's our suppression rate. In the 5 to 9, 86, and in the 10 to 14, we were at 89% suppression rate. So now that we've shown you the picture of how we were performing in the 395s, we want to now share with you the impact, what we saw when during the stop work order. So we will share, these are the slides that we are now sharing with you. So here we are showing you all our MOH21 HIV HMIS indicators, but of our main interest, which speaks to our 95, 95, 95, are the ones that we have highlighted in red. That is the HIV testing, the first 95. You will see at the end there where we are showing you the change, we have a drop, 35% drop in the testing. This was during this stop work order period. Then when you come to the infant DNA PCR test, which is the EID, we had a 21% drop in terms of the testing of these children. Then the last one, which is the testing for HIV for the mothers at first contact, we had a 4% drop. So all these indicators that speak directly to what is happening in the lab were actually impacted or were affected by the stop work order. We can now get to just drilling down to the actual or to the specific tests. And here the viral load. This is our national picture, and we had, in terms of the tests being done during that period, the drop was about 28% drop in what compared to the number of tests that we were seeing before. So we had a 28% drop, and suppression rate as well. Somehow, strangely, it also dropped by 27%. We saw some drop in those who were virally suppressed. Then below there, I'm showing you the number of children. That is the viral load changes for the children. These are the ones who are less than 15. You will see that in the tests, their drop was even higher than when we look at it in terms of the general population, where it is at 28. But the most drop was in the children, which was at 34%. And the same applies for the viral suppression. We saw a huge drop in the children. For coming to TB, TB was not spared. We also saw some drops. So here, what we are showing is just we do have a weekly situation where we track our TB performance. We look at the number of presumptive TB cases, which are in blue, that were seen in that week, as well as then those that the number also that were sent to the lab, which is in red. And then the other one that we look at is actually the total TB notifications, those that were notified, and that's the one in green, the bars in green. So you will see that from week 2 to up to week 4, we were doing fine. We had an upward trajectory. Then come week 5, and if you check your calendars, this is almost the same time that the stop work order was announced, and we started experiencing this drop. And for TB, it was more like immediate because of what the assistant director did refer to, that we have staff like our CBVs and also people who work in the chest clinics, and as well as some staff who were employed just to work in the labs where we had the gene expert to process the TB samples, were now had to go home. So there was all this things happening, and hence that drop that you are seeing. And then afterwards, when it April, we started recovering that somewhere after week 10. So we can proceed. Here we are showing you our VLTAT. So this was before the stop work order. We only had one province whose turnaround time for viral load was at 16.3, and this is based on our eLabs data. This is what is in our eLabs. But after the stop work order, we now had 3 additional provinces now that had that were above the 14 days, because our recommended turnaround time for our VL is 14 days. So all the green we are seeing are the provinces that are below 14 days, and then the red is those that are above 14 days. So these are the effects that we started seeing after the stop work order. This is on our intra-district sample referral system, where we use the motorbikes. And like the director said, that we depend on these motorbikes to actually to send the samples through, and these riders, they were supported wholly by PEPFAR. And so now at this time, during this stop work order, we were now relying on ambulances and people who were moving around for meetings or going for any other thing to carry these samples. So you will see that in January, before the stop work order, we were at 49. We had 49,500 samples coming in. Then come February, we dropped to 36,000. And now that they are back, you see April, suddenly we've jumped. We are now at 98,000 samples being moved around the districts for testing. So from the data that I have shared, so this is just shows that the impact of the stop work order or the aid pause had on laboratory services. So you have seen that our sample transportation was affected, where we now have 4 provinces having their TAT above 14, and also how the numbers of samples that are being transported monthly was actually dropped. Then also the laboratory testing was affected. This is both in terms of the reagents as well as the personnel who were manning these labs. And the laboratory information systems, where we now had delayed results return. And this is mainly for EID, because it was actually completely off, and it was very difficult for us to now return the results to the facilities the way we used to by mobile. We can move to the next slide. And in terms of our response to the drop in the indicators, we can move. We actually now had to set up a committee that had to fast track our journey towards the country's self-reliance and sustainability. So some part of this committee even had to start meeting every week to look at the commodity stock status, as well as the procurements, trying to push what can come in early, and trying to manage the resources. Then we also now had to redeploy GRZ staff to the affected PCR labs and the sections of the labs that were actually filled by the PEPFAR-funded personnel. Then, of course, we had to do quite a number of commodity redistribution, because during that stop work order, it meant that all those commodities that were committed under PEPFAR could not come in, and there was more of no hope of them coming in at all. We had to wait for fresh procurements that we were now doing under GRZ. So we had to share what we had within our facilities. Then now for the TB program, where there were no TB cartridges, we now had to replace it with microscopy. We reverted back to microscopy. This was to ensure that there was continuity of service, because we didn't want presumptive clients coming to the facility and then we tell them we don't have anything that we can test for TB. And for HIV, at that time, we did not have determine. So we did make a decision that we can use the HIV self-test kit, that is the blood-based, the Mylan, that we were now using in place of A1 in the facilities that we didn't have determine. But we did, the few determine that we had, we prioritized it for the children, because you cannot use the Mylan in the children. So that is, those are some of the decisions that we made as a country. We can move. And so beyond the aid freeze, what next? Now that things are back to normal, or that PEPFAR is giving us some of these commodities, does it mean we relax? No, we have decided as a country to now implement our sustainability roadmap, which we had already developed earlier on when we were notified that going forward, there will be some reductions in the funding. So as a country, we had already come up with a sustainability roadmap. And now during the aid freeze, we came up with a minimum healthcare package. So now for us as a country is to implement this to ensure that we sustain our systems. So we will the other thing that we have done, or we have continued doing, is advocacy with the Ministry of Finance and Cabinet for increased budget allocation for health services. Like my Assistant Director mentioned, that even what we were given was not adequate. That is why we had to now come up with a minimum healthcare package. So even after coming up with a minimum healthcare package, what was being given is still not enough. So we will continue advocating that we have an increased budget allocation. And also what we have done is to define and cost the laboratory tests for inclusion into our health insurance benefits package. So this is something that has not been done as a lab, where it's not part of our health insurance, but now we have costed, and we hope we are actually pushing that this be included, and that way it will help with our laboratory testing services. Then we plan on, or we have actually started expanding the VO coverage, that's the viral load coverage, to maintain the viral suppression. And by maintaining the viral suppression, we are also reducing on the advanced HIV disease and also the OIs that can come from that side. They mean making sure that we do not have additional costs that will come through having these advanced HIV disease. Then also we are integrating the HIV surveillance into the national disease surveillance. Before, the HIV surveillance was a standalone, but now we have learned, and we are now just integrating everything into the national systems. This includes even our information systems. They are now being integrated. We are moving away from the siloed systems to the national systems for sustainability. And we have plans to actually develop and update the local laboratory information system software. What we are using, the DISA, which is we have at least an open license, but it's still, we were unsure at the time of the stop work order. So the decision here is to have our own, the locally developed, and also to develop a business model to sustain the biosafety and calibration program. And we were I should say we were blessed that by the time the stop work order was happening, at least some of our critical biosafety cabinets had already been serviced and some equipment calibrated. So our main issue was not really on our biosafety and calibration, but it was on the testing. So, but to be safe, we want to create a business model to actually sustain this, because this is quite an expensive venture. Then also we want to implement reagent rental programs. In the past, we had outright purchases of equipment, which meant that even the reagents had to be purchased somehow. But we want to go using these reagent rental programs where we will have these contracts where they put up the equipment and then they bring the reagents, and everything is factored or sorted through the number of reagents we procure. And also we want to operationalize our PPPs for the diagnostic network. This is our private partnerships. There is actually some strength that our private sector has that we want to actually leverage on and strengthen the diagnostic network. We can move to the next one. And we also plan on establishing our biosafety certification framework. Once this is in place, we are sure that our biosafety program will be able to run or be sustainable. And also, we want to reconfigure the hub and spoke, that is for our sample referral system, where now we are going to just to reduce the distances that the samples have to move. We want to now recruit these riders also under PSMD, that is our government. They have to be now on the government payroll and not dependent on the PEPFAR resources. And also we want to have complete and implement our HRA, that's our Human Resources for Health Transition Plan, that is to have all those staff who were donor supported to now be absorbed in the government structure or government payroll. We can move. And so by the implementation of our minimum health package, and if we are to, and all these other things that we have actually shown you, we are actually going to save about 9.9 million US dollars. This is just from the laboratory budget. This is what we are going to save by discontinuing some of those tests. In terms of money, it might look, if you look at it in terms of dollar, it might look small, but when you convert it to our local rate, that's a huge budget right there. We can move. So in conclusion, what has helped us as a country to actually try and resuscitate what we were losing is actually the political will and commitment from the country's leadership. And the political will started even from the time when we started convening those meetings, the weekly meetings, the monthly meetings. You find that the PS would be there, part of the meeting. So there was indeed, even the minister would always want to get feedback. So that was the kind of political will that we are saying that it is really key if this has to be done. And also integration of services. Siloed programming is expensive, and yeah, going forward, we need to integrate as much as possible, because then we get to make some savings. And we need to have sustainable ways of running sample referral systems, especially for countries like Zambia, whose districts are vast, and a motorbike has to move like for 3 hours to just go and collect a sample. We need to find sustainable ways of running these sample referral systems. We cannot afford to always depend on the partner to support our 72,000 US dollars every month that is required to run the sample referral system. This is all that we had for you, and thank you so much.
Excellent. Stepping in there from Judith, representing the Zambia team. I just want to confirm that Mr. Mweemba is back.
Yes, I'm back.
Great. If you have some quick submissions before we get into the questions and answers, some of probably the side submissions that you thought you would make during the presentation, just before we get to the questions and answers. But before you do that, colleagues, please submit your questions through the Q&A space. The chat is inactive for you, but kindly submit your questions or comments through the Q&A space. Mr. Mweemba, let me get it back to you to just give some of the few submissions that probably would have come through outside the slides during your presentation.
Well, on the apart from the requesting government for additional support, we have also embarked on identifying other interested partners that may have shown interest. We've been in discussions with Melinda Gates and other funders who are shown willingness to come in and cover the gap that the PEPFAR is leaving behind. So that's one thing that us as government and Ministry of Health are doing. I think that's the only additional that I think I should mention here.
Thank you very much. And you're now much more stable with your connectivity, and you'll be handling the questions and comments together with Judith. And again, a very exciting presentation, I must admit. Looking at some of the test packages that can actually be discontinued, but based on data, looking at your data and then discontinuing some test programs, without necessarily compromising the quality of the services that get, quality and safety of the services that get to the clients that we serve in Zambia. I also must admit that we cannot afford to relapse, because the risk of relapsing, even when some elements of funding may have come back, the risk of relapsing and not working towards a sustainable health funding for each of the countries, for all the regions and entirely the continent, that risk is too high to bear. And we can only take foreign assistance as complementary funding and not the only source of funding that we should be looking at. Now, with that, let's get to some of the questions that are coming through, and please keep them coming, and also comments, alternative approaches that some of the other countries are taking, so that then the Zambia team too can learn from you who are attending this session. The first question has come in, and somebody just wants clarity. I think, Judith, you alluded to the fact that you have your electronic sample pickup, and somebody is not very clear. This is Marlene Jumbe. She is not very clear about what an electronic sample pickup means. Are you just speaking to the fact that when samples are picked, they are barcoded, the barcodes are scanned, and then there is a relay of the information even when the samples are moved by the bikes?
Thank you, Francis. And indeed, that is the way you've explained it. That is what I meant. That when the sample is actually collected at the facility and barcoded, so it is entered in the system, and the lab where it's going, they'll already receive the information that this sample is coming with the rider. And it's vice versa, the same. When the results are ready, they just send through the same system, and the people at the facility, they access the results without having to wait for the hard copy result.
Okay, thank you very much. And let me hand it to Mweemba, whose network is still stable. Before it gets unstable, I'm not hoping that it gets unstable. There is the aspect of, we have very good proposals for sustainability, moving the riders to the government payroll outside the partners' payroll, getting equipment through the reagent rentals, and then paying based on what is consumed and then the maintenance actually remains with the vendor and other things. But these are costs that are also significant. And when government has to take it, it has to be planned in the annual budgeting cycles, or sometimes even the strategic budgeting cycles. And so, in your opinion, how soon, what is the absorption timelines for some of these proposals that you're making to government?
Thank you, Francis. I'll begin with the reagent rental model. This we have already started implementing it over years. The only thing that we're doing is strengthening it to include even other pieces of equipment that were not on reagent rentals. So this is ongoing, and so far we have seen a reduction in the expenditure on government side, because we no longer are budgeting for the service of equipment, for repair, or for decommissioning. So that is already in the process. As for the human resource with regards to the riders, the Ministry of Health is undergoing restructuring, looking at the new positions, and we are hoping that we can exploit this opportunity to bring in the issue of the riders that were being paid by our partners. So we are hopeful that come next year, 2026, we will begin to absorb some of these cadres into the government payroll. So right now we are in the process of restructuring process, and we are hoping to use this opportunity to lobby government to include this cadre. Thank you. I present.
Excellent, excellent. Let me get to Judith. And Judith, there is a question on the discontinued tests. And so just for clarity, and I know that some responses are coming through in the chat, and thank you for the team that is supporting with the responses in the chat. But just for clarity, so some of the tests that have been discontinued, can you kindly again come back on them? The baseline EID. No, the EID at birth, sorry. And then the baseline viral load against the first viral load at 6 months. If you could just clarify on those two. And of course, there are the HIV, the screening test where you're doing some of the test methods that are not appropriate for children are being kept, and then those that are appropriate for children are being provided to children. So just to summarize the question, you're no longer doing the EID at birth. If you could explain that a little further, and also the baseline viral load.
Thank you, Francis. So indeed, we are no longer doing the EID at birth. Initially, our algorithm for EID was that we do the test at birth and at 6 weeks. So the reason why we had put up the at birth testing was to cut on the initial loss to follow-ups where the mothers will go and not come back at 6 weeks. So we wanted to capture them before they actually disappeared. So now when we made the decision to drop this the birth one, we looked at our data, and our data showed that actually the same number of people that were having their tests at birth, and also they were still coming back at 6 weeks. And the data also showed that the 6 weeks one, we were getting more, it had more yield than the birth one. So that is how we now made a decision, say, okay, we can discontinue the birth. We will not lose anything because the same people are still coming back at 6 weeks. Then for the baseline viral load, this also, we looked at our data, and mainly for the baseline viral load, why we had to include it was to pick these those that were already on treatment but were still coming back to try and be tested again, the silent transfers. We were trying to capture them. And we were also doing recency study. Those that do recency in your country, you will understand why we needed to do the baseline viral load. But when recency was removed and we now understand the picture that we have concerning the silent transfers, what proportion of the silent transfers that we have. So that is how we arrived at the decision to say, okay, we can do away with the baseline viral load and maintain the viral load at the 6 months viral load. Then on the test for the children, this is not the EID, but for those 2 years and above, where we couldn't use the HIV self-test Mylan kit. You will see even the manufacturer has already indicated that do not use in children less than 15. So to do that, we had to prioritize the little stock of determinant that we have for that group and then move the adults to that we could use the Mylan blood-based test. Thank you.
Excellent. And thank you, Judith. And we recognize the comments that are coming through in the chat that we should get more countries. Some countries might be impacted more than others. And that is true because the scale of support to different regions on the continent and different countries specifically was never the same. So some countries were receiving huge support and others were receiving minimal support, so to speak. And so those that were receiving minimal support are more likely to survive better during the withdrawal of this minimal support that was getting to them. And those that were getting a lot of support, it goes without saying that they must be impacted more significantly. And yes, we will be getting to more countries to make sure that we can share what countries are going through, but most importantly, what it is that they're doing to make sure that they can sustain services delivery. There is a particular question on the impact of the stop work order on external quality assurance for some of the lab services, specific tests that you're doing. I want to expand that to cover general quality management system. We know that most countries have been moving the drive to get labs accredited, labs certified, and of course, with that comes the requirement that routine internal quality control materials should be run and also the external quality assessment performed. Do you already have data showing what the impact is on this quality management systems space for Zambia? I didn't target to anyone. Judith, do you want to?
Mtinta can tackle that. Mtinta is in the QMS department here.
Oh, great.
Francis, please repeat the question.
Just the impact that the funding instability has had on your quality management systems implementation in general, but you can speak to accreditation, certification, and the running of your EQA for the country.
Yeah. So indeed, the way we designed our programs before the stop work order has been affected. We've had basically to reduce the number of visits, on-site visits that we go to do within our quality management systems programs. We've had also to reprioritize our procurements on exactly what we need to procure and what we cannot procure. And we've had also to look at what other sources do we have. For example, under the calibration program that we have, we're building in-country calibration service. So we've decided to build a lot of capacity there because that is local, as opposed to us having to pay for services outside. So within the Ministry of Health, we are able to do our own calibrations. And for the EQA, at least for this year, 2025, we have already been able to procure our requirements for this year. But we are also reprioritizing our funds so that we are able to support EQA going forward after the 2026 cycles come through. So that is how we're trying to handle some of these things. And definitely we are strengthening our in-country EQA programs. We do have an EQA program where we have 5 schemes, the TB, the HIV, the viral load. We're strengthening the microbiology EQA scheme as well and making that in country so that as soon as we do that, we rely less on having to procure the EQA schemes from out of the country. So definitely one thing we're going to do as a country is relook at how we're implementing our QMS programs. For example, we do know that we do have mentorships for QMS going out into the facilities, which were basically 10-day programs, but now we can reduce them to 5 days. And then we also want to decentralize from dealing with central level oversight. We will now go to provincial oversight so that we reduce costs like that. And that is how we're moving on with the programs. Thank you.
Thank you, and an excellent response there. We're running low on time. Let me hand it over to Mr. Mweemba. And Mr. Mweemba, just 2 quick areas that you can help us deal with. The issues around public-private partnership. I know that this is an area that you're also exploring as a country. What are some of the specific areas that you're looking at when it comes to your engagement with the public-private partnership facet of your sustainability plan? That is one. And then 2, we do know that the proposals here will need support from our politicians, from our civil society, and all the other facets of society for us to be able to really get it to the right tables and have the right tone set for their adoption. So what are some of the strategies that we in the lab directorate at the Ministry of Health, or even at the entire level of the Ministry of Health, what are some of the strategies that we are taking to make sure that all these facets of society that are very important in making sure that some of the initiatives are adopted are engaged? So those 2 aspects, and you can try as much to summarize them.
Thank you, Francis. For the PPP with private partners, what we are looking at is the type of machines or instruments that are being brought in the country to test our people. So all recommendations for equipment passes through the Ministry of Health through the validation and the evaluation of the equipment before it can be suitable for use in Zambia. So private entities, they look at our list and decide which machines they can buy as they pass through our evaluation and validation processes. And in terms of involvement of civil society and the politicians, Judy did allude to the fact that we had meetings that were looking at sustainability. And in these meetings, the civil society were also involved. We did not leave them out. They are active participants in our discussions, as well as the political side. We are looking at the minister, who is always briefed when we are doing our planning and lobbying. And quickly, I also want to just respond to the question that Dr. Farouk put forward, where it is talking about how did we move from the gap to the savings. Please take note that that savings is not savings in the retro perspective. This is the money that could be realized from the removing of some of the tests, and this money is not really a saving. It goes towards the upsetting the gap of 31 million that was identified. So it's not really a saving. it still goes back to cover up the gap. Thank you so much.
Excellent. And I will take that as your closing remarks, and I will give an opportunity to Judith if you have any closing remarks in the next 30 seconds.
Thank you so much, Francis, and it's been a great meeting. That is all from me. Thanks.
Great. And really an exciting experience sharing there from the Zambia team colleagues. And it goes without saying that we need to take the opportunities that are around us and make sure that we can develop sustainable service delivery, be they lab services, be they the general healthcare services delivery. We cannot afford not to prepare to bear most of this on our own and take any foreign assistance just as a complement or as a bonus to what it is that we're supposed to be doing to serve our people. Thank you again to the Zambia team and everyone who has been on call. We much appreciate, and we'll be looking out for countries that have moved given the challenges that they've faced with this funding instability, and then they would be willing to share with us some of those experiences, and other countries then can learn from that and move it in the direction of developing very sustainable services provision. So from us, ASLM, we wish you the very best of your morning, afternoon, or evening, wherever you're joining us from, and looking forward to seeing you in our next session again. Thank you and bye for now.